Welcome to our comprehensive exploration of the lacrimal apparatus, an essential component of ocular health. The lacrimal system is responsible for producing and draining tears, which are vital for keeping the surface of the eye moist and free from irritants. In this video, we'll break down the anatomy, function, common disorders, and treatments related to the lacrimal system. Understanding how this system works is crucial for recognizing and managing various eye conditions that can affect comfort and vision. Let's begin by looking at the basic structure and function of the lacrimal apparatus. Lacrimal apparatus is divided into two main parts, the secretory and excretory portions. The secretory portion includes the main lacrimal gland and accessory lacrimal glands, which are located in the conjunctiva. These glands are responsible for producing the lacrimal fluid, commonly known as tears. The main lacrimal gland releases fluid through several small ducts, ensuring that the eye remains lubricated and protected from environmental irritants. The accessory glands provide additional moisture, supporting the overall health of the ocular surface. Excretory portion of the lacrimal apparatus is responsible for draining tears away from the eye. This system includes the punctum, canaliculi, lacrimal sac, and nasolacrimal duct. Tears produced by the glands are spread across the eye and then collected at the inner corner where they enter the puncta. From there, they travel through the canaliculi into the lacrimal sac and finally drain into the nasal cavity via the nasolacrimal duct. This drainage system ensures that excess fluid is efficiently removed, preventing overflow onto the face. Lacrimal fluid, or tears, is a slightly alkaline solution containing water, sugar, sodium chloride, urea, and proteins. It also includes lysozyme, an enzyme with bacteriostatic properties, and immunoglobulins such as Ig-A, Ig-G, and Ig-M. These components help protect the eye from bacterial infections and neutralize viruses and toxins. Interestingly, lacrimal secretion is absent for the first few weeks after birth, but begins soon after. On average, the eye produces between 0.5 to 2.25 ml of tears daily, maintaining a pH of around 7.5. Tears are secreted into the conjunctival sac through 10 to 12 pairs of ducts from the lacrimal gland. The fluid spreads evenly over the eyeball, keeping it moist and ensuring optimal function. As tears reach the inner canthus, they are drained through the puncta into the nasal cavity. This continuous flow not only maintains the health of the eye's external structures, but also helps wash away debris and microorganisms, playing a vital role in ocular hygiene. Watering of the eye is a common symptom that can result from various causes. Two key terms are often used, epiphora and lacrimation. Epiphora refers to watering due to an obstruction in the tear outflow pathway, while lacrimation describes excessive tear production by the lacrimal gland. Understanding the difference between these terms is important for diagnosing the underlying issue and determining the appropriate treatment. Epiphora, or overflow of tears, is typically caused by blockages in the tear drainage system. Common causes include stenosis of the punctum, avulsion of the lower punctum due to age-related laxity of the orbicularis oculi muscle, obstruction in the canaliculi, tumors affecting the lacrimal sac, and various pathologies in the nasolacrimal duct. Identifying the specific cause is essential for effective management and relief of symptoms. Excessive secretion of lacrimal fluid, or lacrimation, can be triggered by a variety of reflex causes. These include the presence of foreign bodies, inflammation of ocular structures, exposure to dust, smoke, irritating gases, bright light, or eye strain. Emotional or psychological factors can also stimulate tear production. In these cases, the lacrimal gland responds to sensory stimulation, resulting in increased tear flow. Dacriocystitis is defined as inflammation of the lacrimal sac. This condition can occur at any age and is often associated with obstruction in the nasolacrimal duct, leading to stagnation of tears and subsequent infection. Dacriocystitis can present as either an acute or chronic condition, each with distinct clinical features and management strategies. Congenital dacriocystitis occurs in newborns due to failure in canalization of the nasolacrimal duct or blockage by epithelial debris. This leads to epiphora, sometimes accompanied by purulent discharge, typically appearing in the second week of life. Applying pressure over the sac may cause regurgitation of mucopurulent material. Early recognition and treatment are crucial to prevent complications. Primary treatment for congenital dacriocystitis is lacrimal massage, which involves applying firm pressure over the sac area and moving downward toward the nose. This technique, performed several times a day, can help open the blocked duct. If infection is present, broad-spectrum antibiotic eye drops are used. Most cases resolve with this approach, but persistent cases may require surgical probing of the nasolacrimal duct under general anesthesia. Chronic dacriocystitis is a long-standing suppurative inflammation of the lacrimal sac, most often due to persistent obstruction of the nasolacrimal duct. It is more common in middle-aged individuals, especially females and those from lower socioeconomic backgrounds. The condition leads to stagnation of tears, creating an environment for secondary bacterial infection and chronic inflammation. Most common cause of chronic dacriocystitis is stricture or narrowing of the nasolacrimal duct. This may result from a narrow bony canal, chronic inflammation of the nasal mucosa, a deviated nasal septum, hypertrophied inferior turbinate, or nasal polyps. These factors lead to stagnation of fluid in the sac, which can become infected by bacteria such as pneumococci, streptococci, or staphylococci, further aggravating the inflammation. Patients with chronic dacriocystitis typically experience persistent watering of the eye, known as epiphora, which may be followed by mucoid or mucopurulent discharge. Swelling over the sac area is also common. These symptoms can significantly impact daily life, causing discomfort and increasing the risk of further complications if left untreated. In the early catarrhal stage of chronic dacryocystitis, there may be mild redness of the conjunctiva near the inner canthus, with little or no regurgitation of fluid when pressure is applied. Swelling over the sac area is typically absent at this stage, making it easy to overlook unless specifically examined. As chronic dacryocystitis progresses to the mucosal stage, conjunctival redness becomes more pronounced, and mucoid discharge can be regurgitated with pressure. Swelling over the sac area is now evident. In some cases, both canaliculi may become blocked, preventing regurgitation and resulting in what is known as an encysted mucosal. In the piosal stage, inflammation intensifies. There is increased conjunctival redness and pressure over the sac produces mucopurulent or purulent discharge. Swelling over the sac area is prominent. If the nasolacrimal stricture is incomplete, the contents of the sac may evacuate into the nose when pressure is applied. Diagnosing chronic dacryocystitis can be challenging, as it may be mistaken for conjunctivitis. A key diagnostic step is to check for regurgitation of mucoid or purulent discharge by pressing over the sac. In uncertain cases, a sac syringing test can confirm the diagnosis by assessing the patency of the nasolacrimal duct. If left untreated, chronic dacryocystitis can lead to several complications. These include acute dacryocystitis, corneal ulcers such as ulcus serpens, and chronic conjunctivitis. Early recognition and management are essential to prevent these potentially serious outcomes. Routine investigations, including X-rays of the paranasal sinuses, are recommended to rule out any underlying nasal pathology that may contribute to chronic dacryocystitis. Identifying and addressing these contributing factors is important for successful treatment and prevention of recurrence. Initial management of chronic dacryocystitis involves repeated sac syringing with antibiotic drops. This can help clear debris and infection from the nasolacrimal duct, especially in the early stages. However, if the condition persists or recurs, surgical intervention may be necessary to restore proper drainage. When medical treatment fails, surgical procedures such as dacryocystectomy (DCT) or dacryocystorhinostomy (DCR) are considered. DCT involves removal of the lacrimal sac, while DCR creates a new drainage pathway between the sac and the nasal cavity. The choice of procedure depends on the patient's age, the severity of disease, and the condition of the sac wall. Dacryocystectomy is typically indicated for elderly patients or after a single attack of acute dacryocystitis, especially when fibrosis of the sac wall prevents successful DCR. This procedure involves complete removal of the lacrimal sac, resulting in lifelong epiphora but eliminating the risk of recurrent infection. DCT procedure begins with local anesthesia using 2% xylocaine with adrenaline, except in hypertensive patients. A curved incision is made near the inner canthus, followed by careful dissection to expose and remove the sac. The lacrimal fossa is cleaned and cauterized, and the wound is sutured for cosmetic purposes. Postoperative care includes firm bandaging, analgesics, and antibiotics. The main complication of dacryocystectomy is lifelong epiphora, as the removal of the sac eliminates the normal drainage pathway for tears. However, this procedure effectively prevents recurrent infections and is often the best option for certain patient groups. Dacryocystorhinostomy is a surgical procedure that creates a direct connection between the lacrimal sac and the nasal cavity, bypassing the blocked nasolacrimal duct. This operation is preferred for younger patients with chronic dacryocystitis as it restores normal tear drainage and prevents epiphora if successful. DCR procedure starts with packing the nasal cavity with a ribbon gauge soaked in local anesthetic. After exposing the lacrimal sac, the lacrimal bone is removed to access the nasal mucosa. Incisions are made in both the sac and mucosa, and their walls are joined to create a new drainage pathway. The wound is then cleaned and dressed, and patency is tested postoperatively by syringing. Complications of DCR include hemorrhage, particularly from the angular vein or nasal mucosa, and failure of the procedure due to a small opening in the lacrimal bone, fragile mucous membranes, or postoperative infection. Proper surgical technique and postoperative care are essential to minimize these risks. Acute dacryocystitis is a sudden, severe inflammation of the lacrimal sac, usually secondary to chronic dacryocystitis. It is characterized by intense pain, swelling, redness, and tenderness over the sac area. The condition often results from superimposed infection by bacteria such as Streptococcus, Pneumococcus, or Staphylococcus. In acute dacryocystitis, pus accumulates in the sac, causing the interior wall to burst and spread inflammation to surrounding tissues. This can lead to abscess formation known as a lacrimal abscess, which may rupture through the skin, forming a lacrimal fistula. Repeated attacks can result in chronic complications and scarring. Patients with acute dacryocystitis experience severe pain and a hot sensation over the sac area, marked swelling, tenderness, and redness of the skin. Regurgitation is usually absent due to blockage of the canaliculi by edema. Other signs include conjunctival congestion, enlarged submaxillary lymph nodes, and if an abscess forms, fluctuation in the sac area. Acute dacryocystitis can lead to serious complications, including osteomyelitis of the lacrimal bone, orbital and facial cellulitis, and cavernous sinus thrombosis due to the spread of infection through the angular vein. Prompt diagnosis and treatment are essential to prevent these life-threatening outcomes. Diagnosis of acute dacryocystitis is based on clinical features such as pain, swelling, redness, and tenderness over the sac area. The absence of regurgitation and the presence of fluctuation or abscess formation help distinguish it from other ocular conditions. Early recognition is key to effective management. Treatment includes hot compresses, local and systemic antibiotics, analgesics, and anti-inflammatory medications. If a lacrimal abscess forms, a vertical incision is made to drain the pus. Once the acute inflammation is controlled, dacryocystectomy may be performed to prevent recurrence. In cases of lacrimal fistula, complete excision of the fistulous tract and sac is necessary. Iriasis palpebrarum is an uncommon condition where the eyelashes become infested with the nits of the crab louse, pediculus pubis, or capitis. This leads to redness and itching of the eyelid margins. Treatment involves applying a 3% ointment of ammoniated mercury 4 times a day for 1 week, along with treating other infested areas to prevent recurrence. Iriasis palpebrarum is a predisposing factor for blepharitis and inflammation of the eyelid margins. Prompt treatment of the infestation is important to prevent secondary complications and maintain eyelid health. Pigmented nevi are gray or pigmented nodules seen at the limbus or near the inner canthus on the conjunctiva. These are congenital, benign tumors that rarely become malignant. However, they tend to grow at puberty, so complete excision before puberty is recommended to prevent complications. Papilloma is a soft, pedunculated tumor of the conjunctiva, often resembling a raspberry or delicate finger-like frond. It may appear at the limbus, inner canthus, or in the fornices. Removal is advised as papillomas have the potential to become malignant if left untreated. Conjunctival cysts are common and include implantation, retention, and lymphatic cysts. These cysts can cause discomfort but are generally benign. Understanding the different types helps guide appropriate management and treatment. Implantation cysts occur when epithelial cells are implanted into the subepithelial tissue, often due to trauma or surgery. They appear as small, round swellings containing clear fluid. While painless, they should be removed if they cause discomfort or interfere with vision. Retention cysts develop due to obstruction of the duct of an accessory lacrimal gland or a mucus gland. These cysts should be removed if they cause discomfort, as they can interfere with normal eye function and comfort. A lymphatic cyst forms when a lymphatic channel in the conjunctiva becomes abnormally dilated and protrudes above the surface. These cysts are lined with endothelium and should be removed if they cause discomfort or visual disturbance. Limbal dermoids are lenticular yellow tumors most commonly found on the temporal portion of the limbus. They consist of epidermoid epithelium with sebaceous glands and hairs. These benign growths tend to enlarge at puberty and should be removed if they cause irritation or interfere with vision. In summary, the lacrimal apparatus plays a crucial role in maintaining ocular health through tear production and drainage. Disorders such as dacryocystitis, epiphora, and various conjunctival tumors can significantly impact eye comfort and function. Early recognition, accurate diagnosis, and appropriate treatment are key to preventing complications and preserving vision. Thank you for joining us on this detailed journey through the anatomy, disorders, and treatments of the lacrimal system. By understanding the structure and function of the lacrimal apparatus, as well as recognizing common conditions and their management, you can better appreciate the importance of ocular health. Stay informed and consult an eye care professional if you notice any symptoms related to tear production or drainage.